My name is Joanna Vautour, if you're just joining us, and I'll be moderating this session. And in this session, if you're just joining us, I have Sebastian to my left, Gerald, Lori, and Julie. So just a reminder for our online audience to share your thoughts or ask questions. You can either put them in the chat box, or if you prefer to remain anonymous, you can add them in the Q&A box located in the menu bar. We also encourage you to join in the conversation by putting your camera on, unmuting yourself, and jumping into the conversation. You can also raise your hand feature, and someone will call upon you to share. And for our in-person audience, there are a number of mic stands in the room. And for the people online to hear, we need you to share your thoughts and questions in one of the microphones located in the room. If you have any mobility issues, you can also raise your hand and someone will bring one of the mics to you. So we will alternate between online and in-person questions and comments and try to get through all the questions and comments for each question. And so just a bit of a recap of the session, if you're jumping into this feedback session with us now. Our panel speakers, Sebastian, talked about the research that they've been doing with 7 First Nation communities in Ontario regarding dementia and how their project is community-led. And we heard from Gerald, who has, do I say how many years? I think about 30 years experience working in home and community care. And he is currently working in Saskatchewan with about 70 plus First Nation communities. And we have Julie and Lori that are joining us from Alzheimer's Society with some great approaches on working with individuals using a palliative care approach. And so the purpose of the feedback sessions is to provide everyone with an opportunity to share the latest happenings in their communities, organizations, and teams in relation to the topics discussed. Whether you are from Indigenous community or working in the space as an ally, we want to create an environment where people are learning from one another, not just from the speakers. We also want to help build new partnerships and connections, create synergies, and share resources and promising or innovative practices that are making a difference in your communities. This is a chance to discuss the challenges you are facing, highlight the strengths that deserve recognition, and perhaps come out of the session with 1 or 2 recommendations or strategies you can implement right away to create change. We hope that you leave this session with fresh ideas and inspiration to help improve care in your communities. This session will be facilitated through some questions posed to the participants using Menti, followed by an open discussion. And we will start with a Menti question that I will ask everyone in the room and online to complete. Once completed, I will then open it up to participants so that you can explore each question further. I think people know how to use Menti right now. I'm seeing folks here in the room with their phones up. The ones online, you can use your phone as well, or you can use the link in the chat box. And you'll arrive to the web page where you'll see those questions. Please don't close the web page. Keep it open because the next question will pop up for you. So you guys are all getting started. You folks are getting started already. First question. What challenges or barriers does your community team experience when it comes to research? Okay, so waiting for responses. If those of you are thinking, okay, how is my brain going to work at this moment? I'm going to give you some little prompts. Sebastian talked about how past research experience where researchers never came back to share those results. It was an Indigenous-led or driven process. Sebastian talked a lot about that. And it wasn't something the community asked for or needed. Sebastian covered a lot of those pieces. Okay, we've got some action happening here. I'm just going to turn my head to look at some of these responses: capacity, funding for positions, finding participants, gaining trust, competency priorities, competing priorities, engaging with communities, staff shortages, and workload overtime. Okay, we cover all the areas of Saskatchewan, an expansive geographic area. Time to build relationships. All right. So as those responses are coming in, I do want to ask one of the panelists, and I'm going to ask Gerald, if he can share one of the challenges, barriers, his community team experience when it comes to research.
Most likely with dealing with our governments, with Indigenous Services Canada, if you want to run and start a new program up in your community, the process of trying to get funding is a long process. It's not just months, it can take years to get funding. For example, in the palliative care program, through non-insured health benefits, there's our items in there that provincially we can get for palliative care clients in communities. Within First Nation communities, non-insured health benefits doesn't always provide the same equipment that we may need to provide that ongoing care for palliative care. The province of Saskatchewan, say barriers are 5 years ago, or going on 6 years ago now, we got the Saskatchewan Health Authority was formed, which is a huge, almost the whole province. We always say we have one health authority in Saskatchewan, but we actually have two. We have the Northern Athabasca Health Authority, AHA, which is a small health authority. But again, networking with them, letting them know our needs. Right now we're dealing with discharge issues. And we actually have a committee set up through FSIN. There's two of us from the home care working and a couple from FSIN, along with the director of First Nation Métis Health in SHA and a few of her co-workers. And we're discussing our concerns about discharge issues. A lot of times you can get information through EMRs. We do have access to the electronic health record in Saskatchewan, but the process is a lot easier now. A few years ago, prior to COVID, it was really hard to get access to that viewer. Our concerns is if the doctor doesn't enter the information on the EHR viewer, then again, we can't get the discharge information. So we're trying to work with SHA on that through this committee. And again, just like we know bureaucracy, very slow moving. We want to, there's a SharePoint the SHA uses that we want to get on and work with them to always update our healthcare program phone numbers and addresses, etc., so that if they need to discharge somebody from the acute care facilities or any of the other organizations, they all know who to contact. So we're diligently working with them, and of course there's an internal process for that. For example, they have the IT people that need to do the SharePoint, they need the policy people that agree how we do this. So internally, it's all the networking that they have to do to move something forward. It takes time. So I wish that could be a lot easier and move a lot faster. So those are a couple things that we see in Saskatchewan.
All right. So Gerald just got it out of his system. I want to check in with the folks that are joining on Zoom. Let's hear about some of those challenges and barriers that you've experienced. I would love if somebody could come on their mic, come on their camera, share with us what is a challenge that you experience. And I don't know, Gerald, do you feel better that you let it out and let everyone hear what the challenges you're experiencing?
Yeah, no problem, yeah.
All right. Let it out. You might feel better after it. Okay. What do we have?
Yeah.
We have some in the Q&A.
Okay, Q&A, if you can read it out for us.
We do have 2 questions in the Q&A from River Woods. And River, if at any point you want to come off and jump in, let me know. The first question is for Sebastian. as a fellow non-Indigenous person, when working with Indigenous communities for research, what are some of the teachings you've been given about working in communities in a good way?
I think the biggest teaching I was given, and it was given to me by Willard, who's in the next room, and I'm sure you guys have met Willard. He told me the Creator gave you 2 ears and 1 mouth. So he's like, you need to listen. He's like, listen, take in what is being told to you, and then speak. You know. So for me, the biggest teaching I've been taught is to listen. You know, don't go into communities and, you know, like tell what you're going to do and say, just sit. Let them talk to you. Let them tell you what their priorities are. Let them lead the way. As an ally, you're a visitor in their communities, and they're welcoming you into their community. So, I mean, you wouldn't go into someone's house and start redecorating their house because you don't necessarily enjoy the view or like the table. Like, you'd want it this way. So, like, when you're in their communities, you go in, you sit down, you listen, and you let them lead the way. And by doing that, and it's a very humbling experience, to really, but then you learn so much, and then it really does become, by listening to their stories, then you get invited to share your opinions, your views, and then it becomes this very reciprocal conversation. So just being very respectful, go in, listen, and then let them lead.
All right, thank you for that question. And do we have another question in the Q&A?
Yeah, well, River just wanted to make a comment that to
Or a
Lori.
comment?
She gets to ask you questions all the time, so she just wanted to say that she's really proud of you, and she's so grateful to continuously learn from you.
Oh, who said that? Is that River?
That was River, yep.
Oh, thank you, River.
Big heart.
All right. How about here in the room? Let's hear it. Sophie, I knew you were going to come up here. Get on the mic because you know what's up. Tell us.
My name is Sophie Pamak. I work as a home care nurse within Nunavut on the East Coast. I got a couple quick questions. The first one was when you're talking about wanting to, our caregivers are stressed and how little support. Is that just related to their diagnosis, or is that just in general, like how some families are really disconnected in that? And the other question, I can't remember who I was going to ask it to, but anyway, when he was up there. Difficulty in getting a diagnosis, Alzheimer's versus dementia, and would it be due to a doctor's ability or experience and comfort level in doing the assessment, dementia versus Alzheimer's? And because we get Alzheimer's, if you get an Alzheimer's diagnosis, you can access those specific meds. So maybe you can't answer, but I was just curious.
All right. Did everyone hear those 2 questions?
Could you repeat question 1 again, please?
Okay.
Which one? The last one?
The first one.
About diagnosis and stuff.
Okay. Wondering if there was any difficulty in getting a diagnosis, dementia versus Alzheimer's.
Oh.
And if there is any difficulty, is it related to doctor comfort in doing that, or the ability to make the diagnosis? Because you can access, without a diagnosis of Alzheimer's, you can't access the Alzheimer meds.
Mm-hmm. And then the first question was about caregiver stress. Is it caregiver stress related to
Is it
the
because
diagnosis?
of the diagnosis, or is it just in general, like
Life experiences?
the family,
Can access the meds.
how they all get along, right? Because sometimes it can be kind of crazy, eh?
Okay. Thank you, Sophie. So would somebody from the panel like to respond to Sophie's question about caregiver stress and what stressors that you have seen related to dementia?
Yeah. As far as caregiver stress, sometimes it's nice to do a survey ahead during the year, like we do in my position. I'll send out always in August requiring feedback by September so that we can look for ongoing training or for the next fiscal year. And that's where we'd look to see what topics need to be discussed. And then, you know, I would do research on what kind of speakers I could get. And in Saskatchewan, we'd go to the Alzheimer's Society, and they would provide the training. And Alzheimer's also has a module on dementia that they talk about. So we'd look at providing that education for them. Of course, that doesn't deal with the caregiver stress right now. So internally, you might have to, you know, get a committee or do some debriefing within. How can we work with our caregivers to help to reduce their stress? And that would be my suggestion.
So Gerald, just to be clear, the role that you do, you work directly with the frontline providers and provide training to them to support those community members, correct?
Yeah. I wouldn't say I work directly. I work with the nurse managers.
Okay.
And through the home care working group, whenever I send out emails talking about training or what needs to, can I assist you in providing care in the home and community care program in Saskatchewan? And they would share the emails and the feedback, get the feedback from their
Great.
staff.
Lori, Julie, from your experience in working with Alzheimer's Society, what can you say with regards to Sophie's question?
Caregiver stress. So one of the things I think we really have to acknowledge that caregiver stress is very individual and unique to every person. And there's a lot of factors that play in that stress. Sometimes it's not just about supporting their loved one living with dementia, but it may be bill paying and family dynamics, access to services. So I think it's really, and it's a disease you can't do alone. It really takes a community. So to pinpoint, you know, where are the stressors and what resource would best support them to hopefully keep that scale at a balance rather than overflowing. And by resources, it might be to home and community care. It may be to the Alzheimer's Society. We need to use those exterior resources to help lessen their stress levels. But it takes a conversation to find out really what carries the most weight in their stress.
Julie?
I think I would add that we need to recognize that a dementia trajectory is a slow one, and there's such a small increment of additional tasks and stressors that happen over time. And you might, as a healthcare professional, walk into a situation that's a bit of a crisis, but this is a crisis years in the making. So I think I would really encourage to think about starting a conversation early about how do we balance things within a family unit or that care unit around that person living with dementia in order to prevent as much of the stressors as we can. Because we need to recognize that, yeah, it's just a slow addition of little things that at some point you get to the point of the straw that broke the camel's back.
Yeah,
Okay.
I agree.
Sebastian, so you talked about, you know, some of the community engagement and those conversations, and there was that, you know, beautiful art and images and words. Can you recall in those sessions any of those participants talking about, you know, caregiver experiences with stress?
Yeah, absolutely. And so we talked extensively with caregivers, so family that are taking care of their loved ones. And I think what my co-panelists are saying is accurate in that it's very individualized per person. But I think that one of the themes that sort of resonated across all the caregivers was that dementia and Alzheimer's is a very isolating illness for the people who have the disease, but also for their loved ones that are now taking care of them. It also becomes very isolating for them. So one of the biggest problems is, so they get into this routine where they are taking care of their loved ones, and so their life at home becomes routine, and so they become used to taking care of their loved ones. But then they're taking care of their loved ones and they're no longer taking care of themselves. So there's no time for self-care. There's no time to get out of the house because they can't leave their loved one alone. And, they become sort of in this routine where they're the primary caregivers and everybody else in their family, maybe not willingly or consciously, who said, well, we'll be there to help, sort of fall off the wayside. And then you get into a household where it's, the person with the disease and the person who's the caregiver, and it just becomes very isolating for both of them. So one of the things that we're working towards is respite care for the caregivers, so that not only do we have, PSWs and those sort of people going in to help with the care, but like allowing the caregiver to leave home and go back out and enjoy their lives, because so if they become too isolated, then they can fall into sort of some despairing situation, some mental illness themselves, and then it becomes even more difficult for them to care.
All right. Thank you. I want us to get to Sophie's second question because it relates to diagnosis of Alzheimer's or dementia and some of the challenges with diagnosis. Laurie, can you answer about, maybe even just talk about what is the difference between the two and what diagnosis looks like for these two unique illnesses?
Right. So first off, I'd just say that Alzheimer's disease is a type of a dementia. And there are many people that don't always know what type of dementia they have. But in BC, it doesn't matter what type of dementia you have access to dementia medications. So it's not just specific to Alzheimer's disease itself. And with Alzheimer's is what causes the symptoms of dementia, such as same thing as like Lewy body, frontal temporal dementia, Korsakoff's. There's many. There's probably close to 100 types of dementias that the Alzheimer's supports. We just don't support Alzheimer's disease.
Okay. And could somebody speak a little bit about, diagnosis and what that might look like? Does anyone have that capacity to do that? Okay.
So I think we know there's no single, I'll just take over. There's no single test to diagnose Alzheimer's disease or dementias. It's really a process of elimination. So we look at possibly delirium. Is a person having dementia-like symptoms because they're having a reaction to medication, perhaps? Are they dehydrated or malnutritioned? Do they have their potassium's out of whack, their blood pressure's out of whack? Maybe they don't know they have diabetes, and they're all showing dementia-like symptoms. But when we fix those, they go back to their normal state. With dementia, you could fix all those, but they'll still have dementia-like symptoms. So the process generally is you have blood tests, you have x-rays, CTs, MMSEs, MoCA, mini-mentals, and if everything comes back normal other than maybe your MMSE or your mini-mental or MoCA, they will often just say probable dementia. Right? Certain dementias, such as vascular disease, if they've had heart issues, strokes, you may see it on a CT and you can pinpoint it to a vent and they'll say you have vascular dementia. But we can also have mixed dementia, such as Alzheimer's disease and vascular dementia, or Alzheimer's disease and Parkinson's. So it's really, again, that process of elimination, and then if the symptoms are still occurring and everything else is normal, it's usually a probable dementia.
All right. Thank you, Sophie. Does that answer your question? Was that helpful? Kind of? Okay. We can talk about it more, but I do want to go on to, we do have someone joining us online that wants to share.
Hi, I just wanted to, one of the participants indicated one of the challenges that she faces. Gloria indicated that there's a lack of nurse educators
Okay, so Monique, thank you so much for that question. Did you say, could that be, could you just, could we have one of the speakers in the back just clarify that question?
Sorry, can you hear me? We don't have access to that question, so I'm not sure. Gloria, did you want to come off mute and share that question? Yes, we can hear you, Gloria.
Okay, thank you, Gloria. Did our panelists hear that question very?
I'll take
Okay.
answer that. Good to see you, Gloria. I'm glad you're online. Gloria is one of our nurses that's has been on the home care working group, so I've known her for many years. As far as special nursing procedures, again, in Saskatchewan for RNs, we call it specialties practices. If it's not in your base nursing training, then you have to expand your scope of practice and receive the education and training and certification process. Again, we're trying to work with SHA that, again, we can network with them and get the training prior to the SHA coming into existence 5-6 years ago, and we had health authorities, regional health authorities, they used to work quite closely with us. We do have in Saskatchewan, there is the Indigenous Services Canada nurse educators. There's a couple there that we can access to say we need this training through the home and community care program. Gloria, I am looking at doing 1 or 2 days special nursing procedures training. I know that may not help you right now. Or also SHA has online courses that you can take. You have to sign in, and I'm busy trying to get the how to map to get onto those training sites to receive that training education. So so we are trying to work forward to making sure that the nurses out there can increase their scope of practice and doing the nursing treatments that they need to do in the province.
Okay. All right. Well, it sounds a bit like we're moving into strengths here, where you're talking about offering training to nurses so that they can support, dementia care. And I'm still sitting with Sophie's question, about, I guess, medical doctors' competency, to diagnose. Would you say that was part of your second question, Sophie? Because it sounded like it wasn't fully answered. Is it their comfort level or?
I'll let you.
Mike's coming.
Yeah, it was the comfort level or the background or both for the doctor in going beyond just a dementia diagnosis.
Mm-hmm. Okay, what have you experienced, Sophie?
Me pushing and pushing and pushing and not getting anywhere.
Yeah, I think about, even the approach of palliative care, where there are some physicians that don't understand, the philosophy and the approach, and Lori's nodding. But I do have to move on to the next Menti question, but we've got this recorded, and I think we'll talk about this recap. when we recap the conversation. So our next Menti question, if folks can get on their phones again or get to that web page, is what strengths and capacities exist in your community team when it comes to research? So we've heard a lot from Sebastian about some of those capacities and strengths. And I'd really like to take a moment and see these responses. So just some prompts. We heard about, community-led. So we'd like to hear from folks on the floor in the room as well as online. What successes have you had with research? Maybe you have your own ethics, protocols, or boards. Only do research with Indigenous scholars and have great partnerships with the university. I'm going to read some of the responses that we have here. Long-term relationship building, as well as commitment from the organization. People generally like to share their life experiences. Availability of our own tribal council nurse navigators at local hospitals. Community expertise, staff with dedicated roles and experience. Consulting the experts. Indigenous advisory boards, yeah. And community members are the experts. Absolutely, the ones with lived experiences in research or in this topic of, dementia care. The family and the community are the experts. So I want to check in with the folks online. If there is anyone that would like to share strengths and capacities that exist in their community care team relating to research or relating to dementia care. Okay. Well, I'll just ask one of our panelists to get us started.
So some strength. So for us, one of the biggest strengths is community. So letting community lead the research, letting the community set the priorities, letting the community set what their outcome goals are is one of the biggest strengths, because by letting community dictate the priorities of the research and drive the research, they're able to come to the conclusions they need to develop the resources and the programming that they themselves need in their communities. So the biggest strength for the research is the community, but more than that, within the community, listening to your elders, the knowledge is already there. The knowledge is already held within the community members. It's held in the land. It's held in the traditional stories. It's held in ceremonies. So, infusing all of that into the research process really strengthen how the research is going to be done. It lets it be done in a good way, and it really sets the stage for the outcomes that then can be used to leverage further research, further programming, further funding. So it's really important when you're doing that research, when you're in community, it's to let them lead.
Okay.
And then just a little bit on partnerships. Really strong partnerships with external organizations helps move the process along. So we've got strong partnerships with McMaster University, where our co-PI is, and we're using their ethics board to be able to do our research. SE Health for training. So just building those strong relationships that help further the research program along.
Okay. Just hearing none come from the ones that are joining us online, I'd like to check with people in the room here if they can share any of the strengths that they have experienced in participating in any research in their community or any initiatives involving, dementia care. Okay.
I can share. Mary Beth Friesen with the Alzheimer's Society of BC. I think that we have grown to have capacity within the organization where we're not just kind of participating in research off the corner of the desk. So having dedicated staff who come to us with knowledge and that work really closely within the organization with staff who are working with people living in community who are experiencing dementia. So we very much have a trusting, collaborative relationship within the organization, and we try really hard to communicate about things that come up so that there's lead time to be able to reach out and talk to people to see if this is something of interest to them. So I think that's a capacity that we have, and again, nothing happens overnight, but it's worth it. It's worth it to take the time and build that foundation.
Yeah, I was thinking about, the time it takes to develop that trust. And, you said it, nothing happens overnight. I'm just kind of curious because, Sebastian, hearing about the memory clinics and also the development of, assessment tools that are, I guess, are culturally safer. Maybe you can just expand a little about that. And these assessment tools, can they be shared, or can other communities access these assessment tools to use in their community? Is there training on how to use the assessment tools?
Yeah, so the Canadian Indigenous Cognitive Assessment Tool, so the KICA tool, is a tool that, so that tool was first developed in Australia, so it's known as the KICA with a K, Kimberley Indigenous Cognitive Assessment Tool. So it was a tool that was brought over from there, and we started adapting it on Manitoulin Island. So it was also translated in Anishinaabe-Moan. And then from there, it also expanded. So there's Kika that was adapted and translated in Nakota. And there's also a Kika version, so it's called the Kika Urban. And it's actually being adapted here in Calgary by an Indigenous researcher at the Calgary University of Calgary, Lindsay Croshu. So those tools are available online. Off the top of my head, I don't know what the website is, but I can get that information. And there is training that is available. So Dr. Jennifer Walker's team offer some training. So they've developed some videos, and the videos show how to do a Kika. And so essentially what the Kika tool is and what our functional assessment tool are, and I think that might help maybe answer a little bit of Sophie's question, is that, so these are not diagnostic tools by any means, but they are tools that are developed and adapted in Indigenous communities that are culturally safe, and they're a way for care providers, so not necessarily just doctor, but we have some of our RNs, PSWs, OT, PTs, when they're assessing their clients, they can do these assessments, and if the client scores below certain thresholds, then it can be an indicator that there could be some form of cognitive decline. And these tools can then, like these results can then be used to accelerate the process to get the clients to see a geriatrician or to see a physician, because they might not have a family physician, so that they can get the diagnoses that they need. So we're working on the development of the functional assessment tool. Edith Mamwe Singh is huge on, anything we develop is to be shared. It's knowledge of the communities to help communities. So once we're done with the functional assessment tool, it will also be available, and hopefully we'll be able to develop some training modules that can be shared either online, virtually, or in person.
Okay. So just one question for you, Sebastian, before we move on to the next mentee. These assessment tools, who would be the ones using them? What clinicians would be using these tools?
So anyone who's been trained can use it. They're fairly simple to use, and it's basically just they ask questions. So there's there'll be like pictures, and they'll be in order, and then they'll be like, look at these pictures, look at what's on the table, okay, or not even just pictures. They'll have like a cup, a spoon, a little a statue of a moose, and then they'll take them away,
Okay.
and they'll be like, can you tell me? So anyone who's trained can give this assessment and bring these back to the healthcare providers.
So you're saying anyone, so could this be a social worker, a nurse, a medical doctor?
Yeah. So
OT?
yeah, our OT.
Okay.
So our OTs are trained to do it. Some of our OTs, some of our PSWs are trained.
Okay. PSWs too. Excellent. All right. So I do have to move on to the next question, but I hope learning about this tool has been helpful. And is everyone familiar with the Kika tool? Hands up if you're familiar with it. No? Okay. People in the room, we learned something new today. Great. How about those online? Could we just check on those online? If we can show the gallery, and if you can just, do a thumbs up on your screen if you are just learning about this tool for the first time.
Yep.
If you can put a thumbs up on the screen. Okay.
We do have an online question from Lois.
Okay.
Within our home care team, we are so limited in numbers and funding that we struggle to provide direct support services. That research always seems to be on the back burner.
Okay, thank you for sharing that comment, because that's going to be helpful, and we'll add that to the report that we're gathering information on. All right, thanks for being with us, everyone. So our last question is, what are one or two things that you or your organization or community can do right now to improve the care? This could also be care related to dementia or care or related to research. One or two things. What can you do to change? And I am going to ask Julie if maybe she would want to, answer what are one or two things, when it comes to research or dementia care, what are one or two things that you or your organization can do right now to improve the care for Indigenous people?
The Alzheimer's Society of Alberta and Northwest Territories has its own research program, so we offer funding for people that do research in the dementia field. And I think the one thing that I want to take back is to look at doing research with the people that live with dementia, not just focus on causes, research, and so that we can develop things or tools or programs that affect those people directly.
Okay, great. So I'm going to go over to our mentee to see what folks online and as well as in the room have shared with us. Community consult. If you're non-Indigenous, read the In Plain Sight report and believe Indigenous people. Thank you. I have not read that report, but I do want to read it as an Indigenous person. Advocate with local politicians and people in power. As Indigenous communities, ask Indigenous communities if you're not part of it, what they want. Increase awareness. Involve Indigenous people in research. As Terry Pratchett said, talk to people. Okay. Excuse me. And continue advocating for organizations to fund dementia research for Indigenous people and keep building our online resources. Thank you. That was a great one. Is there anyone in the room that would like to share a little bit about maybe one or two things that they can see themselves doing to improve research or dementia care in their community? Also, folks online, we invite you to share as well. One of the things I think about, if you are doing any research in your community or organizations, is there Indigenous representation on the research team? So for myself, when I was working with Sebastian, there was myself, there was also an Indigenous research assistant as well. She was my cousin. You know, sometimes how it goes in community, you work with family. Yeah, so we had a fairly large, I would say, the Indigenous representation did outnumber non-Indigenous team members. Okay, anyone happening on the chat? Any questions? Okay, Natalie's giving a nod, no. All right. Okay, we have one here, thank you. Can we go on the mic? Just so that folks on the Zoom can hear you.
More of a question for Sebastian, if that's okay.
Yeah?
I'm Sarah Logan. I'm coming from...
Can you go closer to the mic?
I'm Sarah Logan. I'm coming from Edmonton with George's House and working in collaboration with the Indigenous Wellness Clinic. We're launching some qualitative research and we're just in the preliminary stages with ethics approval and some applications. And I really loved what Sebastian was sharing with including art and the component of having people tell stories. That is kind of what we're looking at in terms of that qualitative component. And I really would like to include that in some way. I think our team is probably more non-Indigenous than Indigenous, so that's certainly somewhere that we could improve. But I'm just wondering, Sebastian, if you've done that qualitative component, if you have any advice moving forward as we're in the really preliminary stages.
I actually...
Or you, Joanna, yes, please.
That's a really good question because I actually know a little bit about Sebastian's qualitative approach and I wanted to ask him it, and it relates to what you're asking. I think he already knows what I'm talking about. I actually had Sebastian do a guest lecture in one of my research courses. And so one of the things Sebastian talked about, was naming research programs, and he shared how one program was named. Sebastian was involved in receiving a message from Spirit and naming a qualitative process on how information was gathered and analyzed. So I'm going to stop right there because I think we've got 10 minutes, but Sebastian, if in 5 minutes, under 5 minutes, if you can tell us about this qualitative research process that you've been a part of working with community and elders.
So,
you know what I'm talking
yeah,
about?
Yeah.
Okay.
So the research, with one of the research labs that I had worked, Morningstar Lodge, they had adapted, so we had worked on adapting a qualitative data analysis method in which basically what you're doing is you're breaking down, because when you're listening to these stories like that, there's a lot of information, right? So you have to sort of sift through the story to get to the meat and potatoes and pick out what's needed to be able to put that into the results and then leverage it later in dissemination. So how we do that is we break the story into little chunks of information, and then basically you take the information and you divide it up on a wall in columns, and basically then the columns become themes. So like you split them into likeness of column to sort of draw power into how much something is relevant in the story. So that was called the collective consensual data analysis procedure. So we had adapted it to make it more streamlined, make it more virtual, make it more just making it quicker, because when you've got 10, 15 interviews that are 1-2 hours long, like it's a lot. So we wanted to have it renamed, and so our PI had given tobacco to our elder, and she burned the tobacco, did a ceremony, didn't get anything from the ancestors. So she did that 3 or 4 times, there was nothing. And so I was visiting in Regina, and we had a sweat lodge, and that night I just had like some wicked dreams. And one of the dreams, I went into the lab, and someone came up to me, I didn't know, like everybody from the lab, like were all my coworkers, this person walked in, didn't know them, came up to me and said, "You're the one that needs to give the tobacco tie to the elder because you did the work, you wrote the paper, so it's got to come from you." And so I did. I gave my elder, I made a tobacco. I was on my way to the airport, rushed to the lab, made tobacco tie, gave it to the elder. I'm like, "Hey, use this." And so she did. That time, she got the name. It was a Cree name, and she's Anishinaabe, so she got the name in Cree. So the acronym was NACPA. So we have further, so in the work that we're doing in these projects, have further, so when I was telling you about the tree and splitting it, putting it onto leaves, so that's more evolving of this procedure. So really what you want to do when you're doing the qualitative data analysis, there's just different ways of doing things, but really what you're looking is for commonality, things that stick out. So what you want to do is you want to try to break it down into chunks and find a way to split it up. And we found that, again, when we're getting elders and community members in a room and we've got things on, on the screen and it's just words and it's white, it's black, it's really boring. Our elders, they start half an hour later, they're like, okay, this is nice, you go do it, we don't want to do this anymore. But when you're using art, when you're using visuals, where you're doing conversation together, it's just a lot easier to do and they get more involved and there's more discussions, there's more. So yeah, so I don't know if that sort of answers but using those visuals
but
really
what's the
help.
name of it? Because the name kind of tells the process.
Oh yeah, so off the top of my head, I can look it up. But
it's
it
a long
was,
name.
yeah, it was NACPA, it's an acronym, and it was Medicine, Stories, Sorted, and Stored.
I think that's good enough.
Yeah. So it was medicine, stories, sorted, and sorted and stored.
Wow. And so that is the approach that they take when they're looking at those stories that have been shared with them. How do they sort them in that data analysis piece? And we know the importance of how those stories are stored and who holds them and who has access to them. So thank you, Sebastian, for sharing that. So I just wanted to check online one more time if there's anyone that is inspired by anything that was just shared with Sebastian as an ally, non-Indigenous person, working with Indigenous community, recognizing their leadership, being engaged, in Indigenous, research methods, through ceremony, through using those medicines and offering tobacco to those elders to share with us. And if anybody else has a story about how they work, with elders in their research. Well, Gerald's going to share with us.
Yeah, just with the Saskatchewan Home Care Working Group, as far as care for the community members, trying to provide that education through our home care programs on dementia and Alzheimer's, if that is the request of the communities. Also, we have a process in Saskatchewan for research. Of course, it's community-led, but we do have the FSIN ethical guidelines that communities can access if they want to do a research program. And there's also the cultural responsive framework that's available in Saskatchewan too, that communities would follow in regards to doing research.
Okay. Did you just say an acronym? And
cultural responsive framework?
FNNH.
FSIN, Federation of Sovereign Indigenous Nations, yes.
Okay, there we go.
Yeah, I think I've said that a number of times this morning.
Yeah. All right.
Yeah.
River
Lori,
just wanted to, sorry. River just wanted to jump in to say that she wants to thank all the speakers so much. There's so many sparks that have been lit for her. And yeah, thank you again.
Thank you so much, River. Well, I hope that everybody had, gained something. Maybe it's one story that they can take back to their communities. Maybe it's one thing that they're thinking about on what they can do to change. Please save our panelists' contact info. I think they are open to anyone reaching out to them to learn more about their work. You can look up Sebastian's name. I believe that article might be available publicly on the process of, what he shared on how they collect data and how they look at those stories. So that's another piece, as well as, take a look into the Kika assessment tool look into the training. Question about that training, is that training free or is it a fee, a cost to take that training to learn how to use those assessment tools?
I'm not sure how the cost
Okay.
goes. That would be something for Jennifer and her team. The website I looked up, it's so you can either reach out to Jennifer Walker and her team. So you can a Google search will bring her up. And also the website is iCare. So i-caare.com/Kika CICA.
Okay. Wonderful. Well, we want to thank you all, for joining us in this session. It was truly an honor to be with these folks here. And before we send them off in a good way, we would like to gift them here and thank them so much for their time, their courage. It is never easy, to sit up on a panel, on a stage, with mics that are pressing on our heads, with lights that are flashing on us and that are hot. So we thank you all for your patience. I want to give thanks to the folks that are sitting in the back that have been monitoring the Zoom chat, that have been making sure our mics and our slides show up, as well as Jessica for putting up the Menti to keep us engaged and to, share and connect, in another way in this virtual world. So I want to say Chimigwich. We say thank you where I am from.